Okay, so good morning, everyone, and today we will start the first lecture on cardiovascular system. And today we will spend an hour, 45 minutes talking about the systematic analysis or interpretation of the ECG or EKG. So patients develop dysrhythmias for different reasons, and we'll start, from the pathophysiology, the EMP pathophysiology, and go over the different types of dysrhythmias. We don't call them arrhythmias because arrhythmias means there is no rhythm. So the better terminology or term to use is dysrhythmia, not arrhythmia. Arrhythmia means the absence of the rhythm. So the dysrhythmia, which is the dysfunctional or abnormal or abnormal rhythm. So anyone has an experience with the analysis or interpretation of the EKG from like other courses, from the job or the work, from employment related, or from any other experiences they have previously?
Yeah, we went through it in a previous course, but we didn't really go very in depth.
You mean Adult Health 1?
Yeah, I think so.
Okay. Yeah, an Adult Health 1, I think they go over some of the very basic stuff. Yeah. But now we are going to do the foundations and the basis and the EMP anatomy and physiology and pathophysiology and how these dysrhythmias occur and develop. But anyone from sometimes we have students who work as CNAs and they are exposed to some type of EKGs. They work on like telemetry.
I work on a telefloor.
Tele? Who's that? I'm sorry.
Khadija.
Oh, telefloor. So you hear all the nurses all the time talking about the EKG and the ECG analysis, right?
Yeah, we read them.
And you can read some of them?
Mm-hmm.
Oh, good for you. So this will be an easy stuff for you now. Okay, so all right, so let's start from the conduction system. So conduction system consists of SA node, which is, what's the other name of the SA node from EMP?
Pacemaker? The pacemaker?
Right, it's a natural pacemaker because we have artificial pacemakers, right? I've seen the patients, when they have a device implanted under the skin, the upper chest, right or left, mostly left upper chest, and that's a pacemaker, and you can feel it under the skin, like a metal, rounded or right under the skin. So that is an artificial pacemaker. So but we have natural, our SA node, natural pacemaker. So when the natural pacemaker fails, then we will implant the artificial one to fix the rhythm. So the artificial pacemaker, when it's implanted, or when we when it's prescribed and it's inserted or implanted for the patient, that's to regulate the rhythm. So the natural conduction system begins with, or it consists of the SA node, which is going to fire the impulse naturally. No batteries, no electricity, no fuel, nothing. It's just natural. It's going to fire the impulse at a regular rhythm, supposedly, healthy, rhythm, then as sinus, normal sinus rhythm, and SR. You will see this terminology all the time in the in the cardiac and the telefluors, NSR, which is normal sinus rhythm. So that's the SA node is going to fire the impulse at a certain rate. So we have a healthy, within defined limits, or what you can call it normal ranges and rates of SA node firing. So it should be between 60 to 100. If the SA node fires the impulse at less than 60, then that becomes a bradycardia, which is here we call it sinus bradycardia. If the SA node fires the impulse at a higher than 100, then becomes a sinus tachycardia. Then after that impulse, so this impulse will originate naturally from the SE node fired, and then after this impulse is being fired, then it will transmit through the atria. So it will innervate the atria, right and left atriums. And then after that, the impulse will reach the AV node. So the AV node will engulf, will take that impulse and transmit it down to the rest of the conduction system. AV node take that impulse, transmit it to the bundle of His, and then to the Purkinje, bundle branches, and then right and left, and then to the Purkinje fibers. So this is the sequence in terms of the pathway of the conduction system. Begins SA node, AV node, and then bundle of His, and then the right and left bundle branches, and then the Purkinje fibers. So the EKG, or the electrocardiogram, which is the mechanical. So let's differentiate between two things: the conduction system and the mechanical force, or the mechanical outcome. So in order for the heart to pump blood, either the right atria or left atria, right ventricle, left ventricle, all of these four chambers, in order to contract, they need electricity, which means they're supposed to, that electrical impulse should precede the mechanical outcome, which is, in other words, mechanical outcome here, it's the contraction. So we need a normal conductive pathway, and a normal pathway for the impulse, innervation, in other ways, you can call it innervation, and then mechanical contraction. So in order for the heart to contract normally, requires to be preceded with a normal and have normal, natural normal innervation. So so differentiate between the innervation, which we are talking about right now, which is the translation of that conduction system, and the innervation of the chambers on the paper, on the EKG strip you are going to analyze, and then the outcome of that will be translated into what is called the outcome, which is the contraction of the chambers. So two things: innervation and contraction. Innervation electrical, contraction physiological or mechanical, which is mechanical outcome.
I'm sorry, can you say that again, with innervation and mechanical?
Yeah, the innervation, which is the pathway of the SA node, of the impulse from the SA node to the AV node to the to the rest of the conduction tree, or conduction system. This is called the pathway of the impulse. It's called the innervation of the heart. Then the resultant effect from the normal innervation, which is the mechanical outcome, which is the pulse, the contraction of the chambers and the heart as a whole. It's called mechanical outcome, or mechanical result. So we have innervation and we have contraction. So innervation, and then will be will be followed by the contraction of the heart. So normally we're supposed to see a normal atrial contraction, which is atrial, we call it atrial click. Atrial click, which is the contraction, the normal contraction from the innervation with the by the SA node. And then after that, you will see contraction from the ventricles, followed by the contraction of the ventricles, and the contraction of the ventricles was the normal continuation on and pathway of the impulse through the conduction system. So innervation and then contraction, or mechanical outcome. So we said the SA node fires at a rate of 60 to 100 beats per minute. Anytime the SA node will fire impulse at less than 60 becomes bradycardia, and the heart rate of or pulsation or firing the impulse rate of more than or higher than 100, then it becomes tachycardia. Then we have the AV node. The AV node, it runs or it the rate of the AV node, it's lower than the SE node. It goes between 40 to 60. And back to the AV node, there is some delay between the SE node to the AV node. That's few seconds of delay. That is a protective mechanism, which is natural, normal, and protective to the cardiovascular system, because that will allow for the atria to have enough time to contract, to empty the blood into the ventricles. Otherwise, if you have like no delay or no time delay at the AV node, then there is no time for the atria to empty the blood to the ventricles. So that's something just to keep in mind in terms of that. The AV node can be considered as a protective mechanism, because there is it will delay the impulse for a few seconds as a protective mechanism to allow for the atria to empty the blood into the ventricles. And then we have some features of the cardiac electrophysiology which is not, this is very specific to cardiac muscle and cardiac cells. You won't find these features in any other cells and in any connective or any type of tissues or cells in our body aside from or outside the heart or myocardium. The myocardium, muscles, and the cells, they have the feature of what is called the automaticity, which is the pacing function, automatic. It's an automatic feature of that. It can pace, which in other words, that I'll explain what one does, what the pacing means. Pacing means that each cell of the cardiac muscle or the myocardium can elicit the impulse and create an impulse that is going to pace the myocardium. In other words, that any cell in the myocardium can be irritated and triggered to become like a pacemaker, like an SE node, but it's not going to result in a normal conduction pathway. It will result in distorted, dysfunctional pathway. And we'll explain, some of these features like, PACs and PVCs. These are the abnormal cells. And anytime the natural pace, natural electrical pathway, SA node, AV node, and the rest of the conduction system, that's natural, that's the normal pathway, electrical pathway or conduction system. Any cell outside of these cells or these parts of, or components of the conduction system, it's going to be called ectopic foci. And you will get to this one in OB when you get to the ectopic pregnancy. Ectopic pregnancy means that the pregnancy that takes place, the inception or the pregnancy that takes place outside the uterus, that is called ectopic pregnancy. Ectopic means outside of normal, or outside of the natural normal system. You can call it that way, or define it as that way. Ectopic, outside of the norm. So ectopic foci for the in EKG, you can refer to the ectopic pregnancy when you want to define the ectopic foci in the cardiac. So in cardiac, ectopic foci means the cell, the cardiac or cardiac cell that's going to elicit the impulse or fire the impulse, and that will pace and innervate the heart, and eventually is going to result in what is called dysrhythmia. And that's sometimes happen from different reasons. We'll go over the etiologies and reasons why patients will develop will have ectopic foci, and why some of these cells will become irritated and triggered and irritated to create the dysrhythmia. So again, the heart, muscles, I'm sorry, the cells in the myocardium has a specific feature that is not present in any other, any other cells, that has the pacing function. Automaticity or pacing function. Second is that excitability is very easily, these muscles can be excited. Sometimes we take too much caffeine, right? We become tachycardiac for some, not everyone, but certain people, they have like sensitivity to, like, let's say, caffeine, and they will become tachycardiac and develop something called SVT from just caffeine intake. So excitability, conductivity, and then contractility. So contractility. So these are the functions of the myocardium in which that the dysrhythmia can occur due to the dysfunctions or changes or alterations of any of these features. Now, etiologies or reasons that may, or causes that may result in the altered cardiac automaticity and result in dysrhythmias. Why patients develop dysrhythmias? Because of any or one or more of these factors. So ischemia, one of them, patient who had developed acute myocardial infarction, or patients who have been diagnosed with a angina, stable versus unstable angina. That's an example of that, which results in the stenosis of the coronary arteries, which is the arteries that's supposed to supply blood and perfusion to the myocardium. So those patients, they will have the myocardium will be deprived of the normal perfusion. Myocardial infarction, electrolyte imbalance, hypoxia, drug toxicity. So you have a long list of reasons why the patients may develop dysrhythmias. Acidosis, alkalosis, fluid electrolytes, patients with hypokalemia, hyperkalemia, that will result in dysrhythmias too. And there's specific features or the changes on the EKG strip that you can identify these electrolyte imbalances, especially with hypokalemia and hyperkalemia with like a tall. With hyperkalemia, patients will have a tall T wave, for example, tall peak T wave. And we'll go over that when we get to the interpretations of the EKG. So first of all, just to get the basics of the EKG in terms of the devices which is going to measure or going to provide us with these results on the strip. It's called EKG strip, which is a piece of paper you run from the tele in the telefloor. We have like each patient is connected to a wireless device, and that monitor is going to display the EKG strip or EKG tracing on the monitor, and they will so that is like a professional or a specialist going to be sitting and watching all of these monitors and seeing if these and in case of the presence of any unusual or dysrhythmia or like threatening dysrhythmia is going to be the alarm will go off, and then the professional specialist will will intervene and run these monitors automatically when there is a life-threatening dysrhythmia. The alarm will go off, and also at the same time the printer will start printing the life-threatening dysrhythmia, so that the specialist or the technician who is sitting and watching these monitors will take an action and will intervene in response accordingly in response to the changes on the monitors and the EKG tracings. So when we say P wave, QRS, and then the T, and then so why some of these? As you review the strip, we will go or just will use only one lead EKG. We are not going to do the analysis using the 12 lead EKG. This might, should apply to the 12 lead EKG, not the one lead EKG. The one lead, which is the one we are going to use and adopt as our, best lead to analyze our EKG, will be lead 2, which is this one. Lead 2, which is right here. This is a 12 lead EKG. 1, 2, 3, AVR, AVL, AVF, and then V1 through V6. So the half of the page, the left half of the page, these are the 6 leads that pertains to the peripheral leads. And I'll explain why we call them peripheral. And then the other half, the 6 leads in the other half, which is the right side of the page of the 12 lead EKG, from V1 to V6, that is called the chest leads EKG. So we have peripheral leads, 6 of them, and we have another 6 chest leads from V1 through V6. And then the peripheral ones are 1, 2, 3, AVR, AVL, AVF. Yeah, abbreviation for this one will be the augmented vector right, augmented vector left, and then augmented vector foot. So these are the peripheral 1, 2, 3, AVR, AVL, AVF. Now we will adopt this one. See how this, if you compare between 1, 2, and 3, and the rest of the leads, each one has a different characteristic or different tracings. Some of the leads, they are negatively deflected. Like look at this one, V2, for example. It's negatively deflected. The QRS is below the x-axis, which is normal. That's normal for the lead. And I'll explain why each lead has a different manifestation or different, characteristic and a different deflection on the tracing or on the paper. So lead 2, so every time in the on these textbooks, as you review the one lead EKG, it has to be one of 2. Either the lead 2, which is most of people adopt as the best lead to use as a one lead, because when we on the monitor on the telefloor, we don't monitor the patient on the 12 lead EKG. And only one lead is going to run all the time, right, Khadija? Khadija,
Right.
can you
Right.
just attest to what I'm saying? Yeah. So we have only one lead. Do you use lead 2 or you?
At my first hospital, yeah, we use lead 2, but it depends because some of them has 6 leads, some has 5, some has 3. It depends on like what the doctor wants.
Good. All right, thank you. So I would say that lead 2 is the best lead among all 12 leads for many reasons. One of the basic things that we have to select the lead 2 as the best one and to adopt it as the best one is that the lead 2 easily can identify the P wave. See how the P wave is nicely deflected above the x-axis. QRS nicely also deflected and presented on the above the x-axis, and the T and the rest. So so the entire rhythm or cycle is nicely presented, and the contour of each segment or section, P wave, QRS, T, everything's nicely presented on the tracing or on the paper. So on the EKG or ECG strip. So from now on, anytime you have one lead analysis or one lead EKG, it will be lead 2. Other hospitals, some they lead something called MCL1, modified chest lead 1, or modified chest lead 2. Yeah, so it depends. Again, I would say that most cardiovascular, textbooks, they adopt lead 2, and even hospitals they adopt lead 2. So why there is some differences between leads, given that 12 leads and it's supposed to give us all the same, or should be similar, given us like the nice deflection of the segments of the cycle like lead 2. It's just because the machine or the device, the EKG machine, as it going to, so the machine or the device, when we attach the electrodes, or when we attach the leads or the electrodes to the patient, the machine is going to look at the heart as as a camera. So the camera cannot get so 12 leads, which means that we have like 12 cameras. 12 cameras are going to be around the heart, looking at the heart from different angles. So that's why you will have different shapes and different tracings on the EKG strip. So I don't want to make it like take more time on for this, just to have an idea. Why would see a different tracings and different manifestations and different tracings on the EKG strip when it comes to 12 lead EKG. So we have peripheral ones. Peripheral, which is lead 1, goes from the right arm to the left arm, and then we have lead 2, which is this is like the direction of the current. It's like electrical current. That's electrical conductivity, and that's the conduction system, right? So, and then we have the right the lead 2, which runs from the right arm to the left foot, and then lead 3, which will run from the left arm to the left foot. So we have lead 1. This is direction of lead 1, 2, and this is lead 3. And then the other three leads, which is called peripheral leads. So we have peripheral leads 1, 2, 3, and we have another 3 peripheral leads, right? So the 3 peripheral leads goes, the center of the leads, or the other 3, is the heart. So these are the 3 leads, 1, 2, 3. So the first one is the AV, we said AVR, which is augmented vector right, goes from the heart to the right arm. Augmented vector left, AVL, goes from the heart to the left arm. And then the last one, which is the augmented vector left, it goes from the heart to the left foot or leg. So these are the directions for the peripheral leads: 1, 2, 3, AVR, AVL, AVF. And then the chest leads, as the old EKG devices or machines, we used to have 12 electrodes. We used to put one on the right arm, another one on the left arm, then one right leg, the left leg. So we have like 12 lead EKG. So we have lots of electrodes to apply in the old machines. And then we have, we'll also apply like all 6 leads right like this on the right side of the sternum, almost third, between the third and fourth intercostal space. You will put the V1, and then on the left side, and keep going like a V shape down to the axilla or axillary area to V6. So this is how we used to place the electrodes. But now with the advent of machines and the advanced machines, we don't have to do all of we don't have to apply 12 leads EKG or 10 or 12 leads. We only apply 3 or 4, right? So we apply only 3 or 4 leads, and it's going to capture the same 12 leads EKG, same as the old machines used to do. So now we are going to apply only, so we have some mnemonic or some, some for how to apply the limb leads, and that's, that needs some experience. And sometimes you need some analogies or things you need to remember, like this, right? Like smoke over fire, snow on grass, or there are, and then the chocolate in the middle or in the center. So these some of the analogies or things to remember, or mnemonic for limb leads in terms of how to apply or how to apply them, because they are color coded. So the lead. So anyway, so even if you apply 3 or 4 leads, it's still going to capture the 12 sides or 12 views, as if the camera is should provide us with 12. The camera is supposed to provide us with 12 pictures taken from 12 angles around the myocardium, which is going to look like this: 12 lead EKG strip. And also at the same time, you will have the printout or the 12 lead EKG strip, or 12 lead EKG printed out or given to you. You will find also in the bottom, always there is one lead running too, which is most of the time it's lead 2. But here the kind of adopted the, V1. V1, as I said, some hospitals, they adopt V1 or modified chest lead 1, MCL1, which is this one, but it's modified one. So this is why you will find 12 leads. So that's the pictures view, taken by the EKG machine, taken from different as a camera, taking the pictures from 12 different views around the myocardium. Now, after we went over the leads, how to apply them, and then the interpretation or at least the presentation of the EKG on the paper. Then now how to measure the intervals on the paper or on the EKG strip. One of the basic assumptions, and most of the time students will overlook this assumption, which is very basic concept and the interpretation of the EKGs, which is when you have an EKG strip like this, just go over strip like this one, don't forget this is like the first thing you would do before you do anything. If you miss this one, and if you overlook this step, the result, the answer is going to be incorrect and will be wrong. Because the EKG strip, especially when you print out the strip, I can give you a strip or EKG strip of 5 inches long. And if you keep printing, you will have it like 50 feet long. So regardless of if you have a strip that is, that is short or long, or it doesn't matter. So we have to identify, so our area has to be, or our length, within that length, you have to analyze the strip within 6-second interval. So if you miss this piece, or you mean like, this step, the result or the answer is automatically is going to be incorrect and wrong. 100% is going to be, will give you a wrong answer. Because if you are going to analyze for heart rate, it's not going to give you the result, the correct answer. Or analyze for anything. So the first thing, you'll get the strip, and then you will identify your, the period or the area, which is the 6-second interval. So going back to, so this is the first thing. What's the method of calculating the length or the 6-second interval? So again, I'm not going to go over the in depth the sources or the history, or what about the measurements, but at least to know that each box has. Let's take a look at the x-axis, and the y-axis. Let's take this one, which is being magnified here, right? So the x-axis will measure the duration it takes for the interval, for the impulse to move from the impulse moving from the SA node to the AV node. How long it took the impulse to travel from the SA node to the AV node. How long it took the impulse to travel to wait at the AV node, which is, we said it's a natural delay at the AV node. And then how long it took the impulse to travel from the AV node to the Purkinje fibers. And then, so it translates the mechanical, or the innervation and the pathway and the steps of the movement of the impulse from the SA node down to the Purkinje fibers, in terms of a duration, in terms of seconds. So each box, large, so this is the large one. This is the large one right here. This is the one magnified here, the large box. The x-axis is reflects the duration. So as you measure the duration on the x-axis from this point to that point, so this one's supposed to be 0.2 seconds. All these 5 small boxes all combined together will come to a 0 point second. So if the impulse took the impulse, let's say a P wave, if the P wave like this from this point to that point, so we'll say the P wave itself is 0.2 seconds. And we'll talk about the PR interval and the QRSs in terms of complexes and how to measure the complex and the intervals. But for now, just to know, so first of all, to identify or to know the duration for each box. So this one is 0.2 seconds, and each small one right here, we have 5 small boxes with n. So this one will be from this point to that point, 0.04 seconds. And if you multiply the 0.04 times 5, will come to 0.2 seconds. So this is the x-axis, and we will be, most of our analysis will be based on the x-axis and the duration and the seconds, and not the y-axis, because the y-axis, it's the, see here, the amplitude, it's the voltage. Like patients with hypertrophy of the myocardium, the impulse will be heightened and it will be exaggerated, and it will, we'll see a peak, tall and high, let's say QRS, which is an R wave in this case, tall R wave, for example, or high voltage or amplitude for the P wave goes up like this, and it's not, which is abnormal, supposed to be nicely deflected positively above the x-axis and in a nice curvature, not peaked or like high than certain, height or voltage. So so most of our, if not all of our analysis will be, focus on the x-axis and the duration and the seconds. We're not going to be concerned about the amplitude or the voltage on the y-axis. So we have now reference ranges and defined limits for each component or each segment of the cardiac cycle. So the cardiac cycle starts from the beginning of the P wave, that's where the SNO is going to innervate the atria, and that's will result in the atrial click and atrial contraction. So the atrial innervation will be presented on the EKG strip as a P wave. So that denotes right here, P wave represents atrial depolarization. In other words, it's the contraction. Repolarization, which is the relaxation, which is U wave right here. The last segment, the last section of the EKG cycle, the cardiac cycle, it's a U wave, and it represents the late ventricular repolarization, which is the relaxation of ventricles to give the ventricles the time for the filling phase. Otherwise, in the absence of the U wave, which means that right after the T wave there is a P wave, then there is no time for the ventricles to fill up or to fill, to fill the blood from the atria. So the filling phase will take place during the U wave. That's the relaxation phase for the ventricles. Repolarization represented on the EKG strip as a U wave. Sometimes not prominent like this, sometimes like straight or, but you will see there is, you can tell from the analysis that, especially like patients with SVT, supraventricular tachycardia, you'll find the cycles goes like, the cardiac cycles will be one after the other. And that's also, it's not, let's see, dysrhythmia. So let's start back to the P wave. So the P wave will represent here the atrial depolarization, which is atrial contraction. And then we have a PR segment, which is from the PR segment, it's not the PR interval. The segment is from the end of P wave to the beginning of the Q wave. and that's the time required for the impulse to travel through the AV node, and that will give the atria the time to fill the blood through the both sides, like the right atria to fill, get the blood from the superior and inferior vena cava, and then the left atria to get the blood and drain the blood from the pulmonary veins. So that's the segment. And then, but what we usually measure is the PR interval. That'd be more important.
Professor.
Yeah.
You said that the PR segment, it is the end of P wave to beginning of what?
The PR segment, yeah. So I said that's the delay. It's the delay. It's the actual PR segment. It's the delay time before the before the signal reach the AV node.
Okay, thank you.
So that's the time for the for the AV node to reach, for the SA. I'm sorry, for the signal to reach the AV node.
Okay, thank you.
And that's the delay needed for for the atrial draining blood into the the atria. So we have P wave contraction, and then that's so segment again. When we measure the intervals, we focus on two main components or segments: the PR interval and the QRS, which is this one, complex.
Okay, thank you.
QT interval, they will be a little advanced because we have something called QTC, which is QT corrected, and we will discuss this in adult health 3. QT interval, it's we correct it. QTC, that's a little advanced. Let's just focus on two main components. The first one is the PR interval, and the other one is the QRS complex. The PR interval, and we have your reference ranges and numbers and lengths for each one. And again, we said the x-axis, we use it to measure these, how long it took the impulse to travel from the SA node to reach the AV node, which is right here, the PR interval. The time from the SA node to the AV node. Now, the QRS, which represents says here, it represents the ventricular depolarization, which in other words, it represents when the atrial contracts. That's a resultant effect from the innervation, which will be presented on the on the EKG strip as a QRS complex. So QRS complex, ventricular repolarization or ventricular contraction. Then we have a T wave. So the T wave represents the ventricular repolarization, which is a complete relaxation phase. And then the U is the late repolarization. It's the time for the cardiac cycle to reset itself. It's like a resetting time to reset for the new cycle. Repolarization, complete repolarization for the ventricles, relax represented by a T wave. So P, Q, R, S, T, and then U. These are the major components of the EKG strip, and this one represents here. So before I move on to next slide, is that you have the reference ranges and lengths for each interval. We focus on two main intervals. The first one is the PR interval, and the other one is the QRS complex. So the first one, as we measure the small boxes, it shouldn't go longer than 3 small boxes up to 5 small boxes. In other words, the 5 small boxes is equivalent to 1 large box. If I go back to here, that the PR interval, as you measure PR interval, which is from the beginning of the P to the beginning of the Q, that's the PR interval. So it should not exceed this length, the 5 small boxes. It goes from 3, or it can be 4, or max of 5. So that's the max is 0. The short one will be 0.12, or I mean, should be less than 0.12, which is 3 small boxes. Because remember, each one is 0.04, 0.04 box. I mean seconds, 0.04 second, and then Liz, yes, Liz.
So Dr. Mickey, what happens if it goes beyond those 5 boxes?
It's a dysrhythmia, and we'll explain what kind of dysrhythmia patient will have. First, we'll identify the norms, and then we'll go over the dysrhythmias after that.
Okay. And you said that the U wave, what happens when that one is present?
It's a late depolarization. It can trigger another step, another impulse, and may result in supraventricular tachycardia.
Is that from when like the ventricles, they're trying to get like excess like blood out before the next cycle? The U wave or no?
No, that's different. No. So the PR interval goes from 3 up to max of 5 small boxes, which is 5 small boxes, which is equivalent to 1 large box, which is this one. This one. So, and then the other complex, which is the QRS complex, should not go for wider than, so QRS, the width right here, as you measure it on the EKG strip, should not wider than, should not be narrower than 0.04, which means 1 small box, 1 small, and not wider than 0.12. You can go up to 3. Actually, this one you can just fix it to 0.12 or 0.12. Sorry, 0.12. So QRS complex can go from 1 small box and not to exceed 3 small boxes. So which means that the PR interval is going to be longer than the QRS. So QRS should go from 1 like this, Q like this, QRS or QRS 2, but not wider than 3. If it's wider than 3, we'll go over that and explain some of the dysrhythmias when the QRSs are wider than 3 small boxes. So PR interval should not exceed or can go from 3 to 5 small boxes, QRS from 1 up to 3 small boxes. And this one explains and try to correlate between the EKG tracing on the EKG strip and the mechanical aspect or outcome of the myocardium. P wave, atrial, TR interval, and then the bundle of Hess, and then the rest of the conduction system, as we discussed earlier. Now, so any questions so far? So before we go to the systematic analysis and calculation of the heart rate from the EKG.
Can you just explain the U wave again? Because I'm not familiar with that till now.
Yeah, the U wave is the late repolarization phase. It's right after, so the repolarization means relaxation phase of the myocardium. Relaxation phase. Right after that, there is a few seconds, very short period of late repolarization, which is you can envision it as the last section or the last phase of the repolarization as a late phase, and that's when the cardiac cycle or the myocardium attempt to reset itself. Resetting needs some time. Resetting means going back to the new cycle. and beginning a new cycle. It's all both connected. T and U are both one phase called repolarization, but the U is a late phase, which is the last section or phase, or the last few seconds of the relaxation repolarization phase. So it's the time for resetting itself, for the myocardium, for cardiac cycle to reset itself, and so it will begin a new cycle. Otherwise, patients the cycles the cardiac or the myocardium will go will develop another cycle on the top of the other one, which will result something called SV, supraventricular tachycardia. So the myocardium needs, a time to reset itself. Is it better now? Clear or?
Yes, thank you.
Okay. Now for calculating the heart rate, the pulse, or heart rate from the EKG, and we said the first assumption, first condition, that we have to delineate or identify the length of the area in which we are going to analyze. You can have a 5 feet long EKG strip, but always first step, always start. This is at the outset of the analysis is to identify the length, which is 6-second interval. And if given that we said that the one always x-axis, we said the y-axis, the amplitude, the voltage. So the length of one large box, we said it's 0.2 seconds. If you multiply the 0.2 seconds times 15, and most of the, I would say, if not all of the EKG strips and paper are measured or marked every 15 boxes, you will find like a dot or a mark or some type of of identification of the beginning and the end of the 15 boxes. So this is from this little dot to the other one here, you will count 15 boxes. So all these papers rolls comes in pre done or pre dotted like this or marked like this. So 15 boxes times 0.2, that's 3 seconds. And then you add another 15 boxes to the other mark. You will find also 15 boxes, which is equivalent to 3 seconds. So you add the 15 and another 15, which is 30 boxes. So which means to get the 6-second interval, you have to count 30 boxes, which is equivalent to the 6-second strip. So for the heart rate to be correct and accurate, we have to count the cardiac cycles within the 6-second interval, which is the 30 boxes. So the heart rate, there are different methods of calculating the heart rate from the EKG strip. First one is to calculate the number of cycles and multiply by 10. And the number of cycles here, you will skip the first R wave. So when we say, the EKG or the rhythm is normal. So normal sinus rhythm or regular. When you say this rhythm is regular, means that for every QRS there is a P wave, or if you say there is a P wave for every QRS. So every QRS should be preceded with a P wave, nicely deflected, all the same shape. So rhythm is regular means that from P to P, P wave to P wave should be consistent across the board for a 10 feet, 100 feet, EKG strip, how long is that EKG strip doesn't matter. So as long as the patient's EKG or patient's rhythm is regular, means that there is a P wave, QRS, and a T wave, and the distance from P to P should be consistent. If you measure it from P to P, should be the same distance across the board. Same thing for the QRS. R wave to R wave, R to R wave should also be consistent in terms of the length, which is we always use the x-axis, and we know our measurement that the large box is 0.2 seconds and the small one is 0.04 seconds. So R wave to R wave is supposed to be consistent as long as the patient's rhythm is regular. So the heart rate, first assumption is that, first of all, to calculate the heart rate, you need to identify delineate or to find out what is your 6-second strip, the 30 boxes. Second, make sure it's regular rhythm. Otherwise, if it's irregular, then you cannot use this method. It's not going to give you the accurate results and correct result, because that's to be another second assumption is that the rhythm is regular. So once it's regular, we're going to count cycles. We skip the first R wave, cycle 1, 2, 3, 4, 5, 6, 7, 8, and I don't see, 8. So within the 6-second strip or the 30 boxes, we counted 8 cardiac cycles. So the 8 cardiac cycles times 10, that will give you an approximate heart rate of 80. And again, this is not 100% accurate. Patient's heart rate could be 83, 82, 84, 79, 78, but it's around 80. It's not 100. Heart rate is not 110. Patient's heart rate is not 40 or 50 or 60. It's around 80. Yes, Liz?
So Dr. Mickey, we skip only the first QRS or
It's
just,
not cross. We're counting R waves.
okay.
This is the R wave. This is the peak tip here. It's the denotes or represents the R wave. So we count R wave to R wave.
Okay.
Because the assumption, if that's the regular rhythm, then the P to P should be the same distance across the board for any cycle. Same thing for T to T wave and the R wave to R wave. But mostly we use our P wave and the R wave for these type of measurements. And I would say that, always use the R wave. If you're gonna figure out if the rhythm is regular or not, see if the R wave to R wave is consistent, the same distance. Has to be like, 3 boxes and 2 small boxes. If that's around this number, like 3 large boxes, which is 3 times 5, 15, and then another 2, about like 17 small boxes. So if that's the case, you will keep, as you keep analyzing, that's consistent, 17 boxes, small boxes, or 3 large and 2 small, then that is a regular rhythm. And then I will count cycles. Skip the first, because cycle means you skip the first R wave. 1 like this. And then you will multiply that number by 10, and that will be the patient's heart rate. The other method is that the large box R wave to R wave, and the distance from R wave to R wave is very close. Patient will have tachy or bradycardia when the R wave to R wave are very close to each other. It'll be tachy or brady, tachycardia. So anytime you find that the R wave is closer to the R wave, then that will be tachycardia. So as the R wave is placed or spaced farther, or far from another R wave. Let's say that your patient's R wave, the first one is here, this is the first one, and the second one is this one, number 4, and nothing here. It's like in between, there is no R waves. Then that will be your patient's heart rate will have 1, 2, 3, 4 boxes. Like this patient has 1, 2, 3, and the 4 will be right here. So if the R wave falls in here, which is this scenario, your patient's heart rate will be 60. See this I'm sorry, no. 75. See number 4. If your patient's R wave falls in like this, the first one here, and then the next one right there. So I'll give you an example of on the EKG strip, this one here. So R wave, and then another R wave, next R wave falls in right the beginning of the second large box. R wave, another R wave. Your patient's heart rate is 300. In other words, that you will count the number of large boxes between R waves. So this is one large box, second, 3, 4, 5 large boxes. So you'll find, so from R wave to R wave, how many large boxes? If there's only one large box and then there is an R wave falls in here, then that is, the heart rate is 300. If the heart rate falls in right after, like there is only 2 large boxes in between, then the heart rate is 150. 3 large boxes, about 100. See how is patient's heart rate here is 80 because the distance between, or the number of large boxes between R wave to R wave is 3 plus 3 large boxes and another 3 or 2 or 3 small boxes on the top of the 3 large boxes. So that's why it's less than 100. Otherwise, it would be a 100.
Professor, I have a question.
Yes.
Just because the boxes and blocks is a little confusing. When you say large boxes, are you referring to the block?
This one, this box.
5 each little boxes?
This little box, yes.
Right. And then, okay.
Yeah. This is the large one.
Okay.
And the small in between, within, there is 5 within the large box. 5 small ones.
Thank you.
So there is, yeah. So there is 1, 2, 3 plus 3 large, and then another like 2 or 3 small ones. So this is another method of calculating the heart rate. So dysrhythmias, let's take this example of a EKG strip and try to analyze it. So as we analyze the EKG strip, there is a systematic method of the analysis, and I believe that I listed here the analysis. So to just practice one example of heart rate calculation from the EKG strip. So step 1 is to determine the distance or the interval, which is a 6-second strip, which is the 30 boxes. So I want to begin from the beginning. Always, if you can, if you try your best to, if you can begin from you begin the interval from the R with the coincide, or should go with the R wave if you can. So you'll have a better counting and better result. So if you begin, so it looks like the beginning of the interval here coincides exactly with the R wave. So now we will count 1, 2, 3, 4, 5, 6, 7, 8, and then here we have 9. So I know that the R wave kind of passed the end of the interval with I would say 3 small boxes, but I would not ignore it because the R wave to R wave, you have about 4 large boxes. So I would not ignore the 3 small boxes because that's very close to again, this when you do this type of method of heart rate calculations, it's not going to give you the exact heart rate for patients like the actual heart rate, but it's going to provide you with some I would say approximation and some estimate number to the patient's actual heart rate. So this patient, if you go with only 8 cycles, then patient's heart rate will be 80, but actually patients is higher than 80 because you will ignore 2/3 of the the last cycle. So I would include the last one too. So that's 9 times 10, and that would be 90. So the systematic analysis of the EKG, again, these are the 2 intervals, PR interval and the QRS complex. PR interval goes from 3 small to 5 small boxes, or which is 1 large box. And then the QRS should not be narrower than 1 small box or wider than 3 small boxes. And you will ask a few questions to yourself as you analyze, systematically analyze, the EKG strip. Our P waves are present. So like the P wave, for example, the absence of P wave means there is no, we'll find some life-threatening dysrhythmias. There is no P wave, which means that, the QRS came right from the ventricles without having the in the absence of the P wave and the EKG strip and the cycle. So we had a ventricular contraction without atrial contraction, and that's life. I mean, not necessarily has to be life-threatening. Sometimes we have something called PVC, premature ventricular contraction, in which that you will not find a P wave on the PVC, no P wave. So you will just follow these steps and questions, and as you answer them, you will be able to analyze. I would say partially analyze. Maybe most of the analysis will come from answering these questions. But let's just take a look. Take a look at the artifact, and then I'll give you some example of or a few examples of the dysrhythmias. So you will just start to practice and build. And anyways, I'm going to visit that. We'll continue the EKG on Tuesday. So Tuesday will be the other lecture on EKG interpretation. So for now, just get the basics, the systematic analysis, how to do the heart rate calculations from the EKG, the compositional or of the EKG strip, and how to read it. The artifact, which is in other words that that sometimes you will run into scenario that you're sitting at the the Intelli and you see one of the monitors is printing sheets like that, or strips like EKG strips like this. So we don't know if this is the actual patients like real EKG or electrical conductivity, or this could be patients, because if that's the patients, the actual real actual cardiac rhythm, it is life-threatening. If not, then that could be an artifact, and that's just could be that the leads are something wrong with the remote. I mean with the device. Could be loose electrodes. Could be patients moving. So it could be one of lots of options or reasons that the monitor is showing these artifacts. The nursing intervention should be to check on the patient physically. If you can call the patient right away, the call light, or you can have on the intercom or on the type of communication with the patient right away, you can do that. Otherwise, you have to check on the patient, because that could be not an artifact, could be life-threatening dysrhythmia. So normal sinus rhythm. This is what we have discussed, over the last, an hour. The whole lecture was going over the normal sinus rhythm. That we analyze it that we have a P wave, nicely deflected, nice contour above the x-axis, followed by QRS and a T wave, and then P, QRS, T wave, P, QRS, T wave. And if you calculate the P to P should be the same distance, same thing, QRS, R wave to R wave should be the same distance. And that's what give you the analysis or the result that this is a normal sinus rhythm. Main causes of dysrhythmias and 12-lead EKG. Now, dysrhythmias, we have tachy and brady dysrhythmias. Tachy dysrhythmias, and these are some of the reasons, either perfusion, deprivation, or coronary artery stenosis or blockage, blood clot, decreased cardiac output, increased myocardial oxygen demand. Patients shoveling the snow, right? And they got into cardiac, the myocardium required and needed more of oxygenation and perfusion, especially if they have like angina or history of, of any type of cardiac disease, then that will be a problem or may result in dysrhythmias. And we hear all the time of, patients who have developed life-threatening dysrhythmias and they passed away during, during the snow shoveling or during like extraneous exercise or even on the treadmill. That's something also similar to this scenario. Due to the dysrhythmias has resulted from the extraneous exercise or activity that resulted in increased myocardial oxygen demand. Now, the tachy dysrhythmias, and this is the brady dysrhythmias, premature complexes, escape rhythms. Yeah, I will go over the the different dysrhythmias, and practical analysis will make more sense, I believe, and then we can can review this right after. So let's go to the how to analyze and do the analysis interpretation of the rhythm. It's sinus brady or sinus tachycardia. So so analyzing this rhythm, so P wave QRS and then T wave P QRS. Even the T is inverted, that's fine. P QRS and then T P QRS. So since that we have a P wave preceding each QRS, so that's across the board, you can, and this is a normal sinus rhythm, but we don't know still if this is a normal sinus rhythm, but we don't know if that's within range in terms of how many beats per minute. If that's within 60 to 100, if that's out of that range, then that's either it's brady or tachycardia. So nothing wrong with the P wave to P wave or R wave to R wave. It's consistent in terms of distance. And P wave is nicely deflected, contour, shape, everything's fine. All P waves look alike. They always should be similar and look, all should be, the same morphology, the same curvature, the same amplitude, the same should be always look alike. These all P waves across the board. Same thing for the R wave, which is the QRS. QRS also should pretty much be look alike, and they are all similar. So everything looks fine except for one thing. If you can't count the R wave to R wave, or let's use the times 10 method or cycles times 10. So counting cycles 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. This is the end of the 6-second strip. And this is the beginning of the 6-second strip. And I counted 11 cycles times 10, 110. So the patient's heart rate exceeded the 100 beats per minute. So this is a normal sinus tachycardia. But just we call it sinus tachycardia. But it is it's a normal rhythm is normal because the P wave, P to P and R wave to R wave is consistent in terms of the duration and the distance.
Professor.
Yes.
So, because I just wanted to know, when do you know when to take that other wave? Because there was like one AKG before this that you took one more.
Yeah. There's only one small box right here. The other one was about like 3 small boxes. And this one is within. This is within. If you want to count this, it's going to be way further than, right? So almost you're adding like 2 large boxes, 2 and 2 small too. So like 2 times 5, 10, and 2, 12 small boxes. That's a lot. Between, I would say, like 2 small boxes, 3 small boxes, around that number. I would, that's fine to go like, higher or lower. That's fine. But if you don't, but you have to count this one, this one, because that's within the 6 seconds. The other one was outside. Now the sinus bradycardia, and see how is the sinus tachy, the R wave to R wave very close, to each other. And now you look at the R wave to R wave are, far from each other. So we have a kind of longer distance than the previous EKG strip, which is the sinus tachycardia. So we analyze the same thing, P wave, QRS. So P wave is nicely deflected, QRS also QRS nicely deflected on the y axis, and then the T wave, and then the P QRS, T, P QRS, and then T. So as you move along and you try to analyze the whole strip, at least within the 6-second strip analysis, you'll find there is a rhythm that is normal. P to P, the same distance from this P to the next P wave to the next P, the same distance. Same thing with R wave to R wave. As you measure it, it's the same distance, consistent. And also the shapes are pretty much the same. P wave and P, all P waves look alike, or QRSs look alike, they're all similar. Now, none of these QRSs are like different, or P waves is different. So then we'll have a normal sinus rhythm, but this one is, well, will tell us if this is if there is any, to identify any dysrhythmia, you will find out from the calculation of the heart rate. So our pre-marked dots are for the 6-second strip falls in here, and then another one here. So we have 15 and 15, 30 boxes. So this is our 6-second strip, and we'll start counting the cycles. And we will count 1, 2, 3, 4, 5. So this patient's heart rate is 5 times 10, 50. But the actual heart rate was 52. So we were very, very close using that method. The calculation method was very close to the patient's actual heart rate, which is 52. So patient's 52, it's sinus bradycardia. So the rhythm is regular, but the rate is out of the norm, or it's not within defined limits. It's out of the range. Range is 60 to 100, and it's less than 60. So this patient has sinus bradycardia. Let's take another. Yes, go ahead.
But the T wave looks like it's a QRS wave.
Try not to focus too much on the T wave now, because EKG or ECG interpretation, it's there is classes that you go to advanced, courses. You will spend like months. If you go to the ICU or CCU, you will spend like months of classes to go over these, this stuff. So don't pick, or stick to to these little nuances, or different shapes, or focus on the P wave and the QRS for now. Yeah, this is our focus for P wave and QRS, and then the durations and how to do the calculations. I know nothing, the EKG strip, because this is an actual real EKG strip, because it's not going to be like in the textbook. They have it nicely presented, and they have it like, this is an actual real patient. That's why you'll see like little differences from the textbook ones. But when so sinus brady, sinus tachy, let's just do one more, which is PAC. premature atrial contraction. And how it's different from the premature ventricular contraction. The premature atrial contraction, which means that the atria had been innervated or were innervated prematurely. So there are more than one indication to analyze the PAC or to find the PAC, premature atrial complex or premature atrial contraction. When you analyze to find out if this is a PAC, one of the tips is to, as you analyze the P wave to P wave, consistent in terms of the distance, how many large boxes, or count the small ones between P to P. So we have 1, 2, 3, about 4 large. Let's say approximate 4 large boxes from P wave to P wave. P wave to P wave, we have about little more than 4 large boxes. Same thing, it should be from this one to the next P wave, about 4 large boxes. Or in other words, it's about like 20 small ones. From this P wave to the other one or the next one, same distance and then same distance. And look at this one. This P wave, what's the distance between, or the, how many boxes between this P wave and this one? About 1, 2, almost 3 or less, little, less than 3 large boxes. So we have about 1, 2, which is 10, yeah, let's say 3 large boxes. So from this P wave to P wave, it's no longer 4 large boxes, it's only 3. So this P wave came prematurely. Which means that one of the cells in the myocardium in the atria were excited to fire the impulse, or were triggered to fire the impulse. Irritation could have resulted to make this what is called the ectopic foci in the atria to fire the impulse. So the ectopic foci in the atria fired this impulse, which is presented as a PAC, as the P. So first of all, the P wave comes prematurely. Second indication that the PAC, the P wave, will be different from the rest of the P waves. It doesn't look similar to the rest of the P waves, very different. The third indication is that the R wave will be also fall prematurely. So P wave premature, P wave is not the same as the rest of doesn't resemble the rest of the P waves. And then the R wave came prematurely because the QRS here responded, or the ventricles kind of reacted and responded to the ectopic foci, which has fired the impulse. So who fired the impulse? Ectopic foci. It's not, didn't come from the SA node to the AV. It was from the ectopic foci. That's why you have abnormal, distorted P wave came prematurely. R wave came prematurely, but nothing wrong with the QRSs because the ventricles reacted normally to the ectopic foci, and knowing that this came from the ectopic foci and not from the SA node. So that's why you would have a normal QRS. So this is a PAC. One of the most difficult dysrhythmias to identify and to find out is the PAC, because everything looks normal. P wave, T wave, QRS, everything looks fine. But what you will find, so these are the 3, I would say, tips how to identify the PAC. Anytime you find a P wave that is different from, doesn't look or resemble or look like the rest of the P waves, and when it comes prematurely, and when the R wave comes prematurely. And QRSs, it's nothing wrong with QRS, is normal, nothing wrong with it. So the PAC 3 main tips how to identify them. And because I want to go to the PVC before going to the SVT and the rest of the and AFib, and because all of these are atrial dysrhythmias, and then the PVC, premature ventricular contraction, which is this one, the PVC, the premature, this is premature ventricular, not premature atrial. The ventricles, in the ventricles, there is one or more ectopic foci in the ventricles, is going to be irritated and fire the impulse and innervate and do the pacing. In other words, pace the ventricles. That's why you will find a QRS that is distorted, QRS that is abnormal, doesn't look like the rest of the QRSs, the normal natural ones, and it's not preceded by a P wave. So these are the features of the PVC, how it's different from the PAC. And the PAC QRS is fine. It's the same normal compared to the rest of the QRSs. Here, it's a ventricular problem because the ectopic foci came from the ventricles. One of the cells in the ventricles, one or more cells in the ventricles had fired the impulse and resulted in a premature ventricular contraction. So obviously the ectopic foci is going to fire the impulse. Yes.
What's that word you're saying?
Ectopic.
I don't know how to pronounce it. Erectophobi or something.
Is it the ectopic foci?
Yeah,
You
yeah,
mean? Yeah, ectopic foci, FOCI, which means like a focus cell, which which fires the impulse and pace the heart or pace the ventricles. And the same with atrial too, ectopic foci. It's a cell that is going to be excited and irritated and then fire the impulse. Same thing with the ventricles. If the ventricles, when this is the ventricles fire the impulse, obviously is going to result in something called PVC, premature ventricular contraction or complex. So the premature ventricular contraction or complex, three things would identify it. First is that it's not preceded with the P wave, because this is a T wave. Second is that the QRS is distorted and wide, and it's different from the rest of the QRSs, the normal natural ones that have been resulted from, from the normal conduction system, SE node, AV node, right? And then the third feature is that the R wave will come prematurely, or the whole complex came prematurely. And if you count the R wave to R wave, it's about 3 large boxes. And then this complex came prematurely after the second box. And then we have a delay time. So with the PAC and the PVC, PAC and PVC, premature atrial or premature ventricular complex, after the abnormal or the premature complex, you'll find a delay time. See how long is it? It took the heart to reset itself after the PVC. 1, 2, 3, about 4 large boxes until the normal cycle had started, which is a compensation method. So the heart needs some time, compensatory phase or pause is needed for the heart to reset itself. Compensatory pause, which is the lung. So this is another feature of, or tip to identify the PVC. And the PAC, the same thing too, is that the PAC, there is a compensatory pause. See here, how's the PAC? After this, the PAC, there is a longer period than the previous, because this is natural, supposed to be 1, 2, 3, 4 large boxes. We have now 1, 2, 3, 4. I'm sorry, 1, 2, 3, 4, 5, and almost like 5.5 large boxes. So this is a compensatory pause for the normal cycle or for the myocardium to reset itself, the conduction system to reset itself. And the same thing for the PVC, that is a compensatory pause. And then next week, we will continue with the EKG